So, welcome everybody. Welcome, Danny. I would like to say that this is the third of a series of community meetings around PrEP with different topics and with selected specialists and experts. And the aim is that we provide information and support the growing of knowledge around PrEP use, especially now that we have the proposal plan for official implementation of PrEP in Cyprus, approved by the Minister of Health. And we are in the process to have a roadmap for implementation. Thus, the AIDS Solidarity Movement started the Cyprus PrEP Points. We launched it on the 29th of May, and I will post on the chat the links of the video of that first launch, together with the rest of the links and the schedule for the rest of the PrEP month community meetings and sessions that we have planned. We are planning to disseminate these videos later on after the PrEP month and after we subtitle everything in Greek and in English, vice versa, depending on the language. Just to say that the Cyprus PrEP Point is the community information and empowerment center of the AIDS Solidarity Movement, providing information and support and guidance to people who choose to use PrEP while it's not officially available in Cyprus yet. The session is recorded. Let's keep the cameras and microphones closed until the end of the presentation. And when we finish with the presentation, we will have an open discussion. I will stop the recording and we can have an open discussion in a safe space, either using your microphones, cameras, or the chat if you don't want to have your cameras or microphones open. So I would like to welcome and thank Dr. Danny Alon Ellenbogen, who is a clinical associate professor of internal medicine and infectious diseases and associate director of the MD program at the University of Nicosia Medical School. Danny, thank you for being with us.
Thank you for having me.
So the floor is yours.
Thank you. Thank you. Well, of course, first and foremost, I would like to thank Christos and the HIV Solidarity Movement for this truly remarkable initiative. And I will be talking today quite shortly, not too long, about the recommended follow-up while an individual is on PrEP. So I'm sure that by now you're all PrEP experts. You've had so many talks and lectures about the topic, and you all know that it is a medication that you can take in order to help you protect yourself from HIV. And it is meant for people who, of course, do not have the virus to be used in order to protect them while they might be potentially exposed to the virus, either through sex or through injection drug use. And today our focus, of course, will be sexual exposure. So if you're sexually active, you should know that PrEP is an option for you, an option that can help you reduce the risk of getting HIV substantially. And if you're interested in taking PrEP, you should ask about it, even if you do not think that you officially belong to a certain high-risk group. And PrEP can be taken today in different forms that can suit your preferences, can suit your needs. And the professional healthcare professionals or the experts of the HIV Solidarity Movement can help you choose the best option for you. However, we should, of course, not forget that PrEP is not a standalone thing. It is most effective when it is an element, part of a broader plan to protect yourself from HIV. So it's another tool in our toolbox of preventive medicine. And this plan might include, of course, taking PrEP as prescribed, because, of course, the effectiveness of PrEP depends significantly on adherence to treatment. I've had many people on PEP. The only one that's got HIV was the one who was not adherent to the recommended regimen. Of course, the plan also includes using condoms properly, getting regularly tested for HIV and for other sexually transmitted infections. We'll talk about that in a minute. And of course, one should consider other ways to reduce personal risk of HIV. For instance, not having sex while on under the influence of alcohol or drugs or whatever you can think that's best for you, depending on your preferences, your lifestyle, that can reduce your personal risk of acquiring of getting HIV. Now, everything that I will be discussing today is based on recommendations of professional recommendations provided either by the CDC, by the American CDC, or by the EACTS. EACTS stands for the European AIDS Clinical Society, or the combination of both. So let's see who should be taking PrEP. What are the current recommendations? And I'll walk you through this diagram quite quickly. It's very simple and straightforward. So, of course, to begin with, a person should be sexually active, and once they are sexually active, they should ask themselves whether they have had any partners whose HIV status within the last 6 months was unknown. If that is not the case, then PrEP could be prescribed, but the indication to prescribe PrEP is quite weak. However, if the answer is yes, then the next question is whether sex was protected. If someone has been practicing protected sex using condoms, then again, the significance of PrEP, if condoms are being used properly and consistently, diminishes substantially. However, if that is not the case, then PrEP should be prescribed. There is an indication to prescribe PrEP. Another branching here of this diagram is whether a person, the individual taking PrEP, has been having any bacterial sexually transmitted infection within the past 6 months. And by bacterial sexually transmitted infection, we mean one of these three when it comes to MSMs, for men, when it comes to men who have sex with men, gonorrhea, chlamydia, or syphilis. And when it comes to men who have sex with women or women who have sex with men, it's either gonorrhea or syphilis only, because the bar is a bit higher, set a bit higher, because the risk of acquiring HIV is a bit lower. And chlamydia was left out here. And if the answer is yes, then there is an indication to prescribe to take PrEP. So, of course, when someone considers taking PrEP, we must make sure that the person who wishes to take PrEP is HIV negative when starting PrEP. Otherwise, they should be receiving full antiretroviral therapy for their infection, of course. So, if you haven't been on PrEP or PEP, which stands for post-exposure prophylaxis, in the past 3 months and have not been using an injectable agent, this represents here, this injectable agent represents here another modality of providing PrEP, which is not available in Cyprus right now. It is basically a drug that is injected at the beginning every 1 month and going forward every 2 months. So if this is not the case, so we're talking about a person who is antiretroviral drug naive, hasn't been using PrEP or PEP within the last 3 months, or hasn't been using any injectables within the last year, then we move on and perform an HIV test. Now, this should be a blood test that is sent to a proper laboratory. However, we must, if someone wants to start immediately, there's an option to do so without waiting for the official result of the laboratory test. You can also perform a rapid antigen antibody test, a point-of-care test, such as the one the HIV Solidarity Movement provides, and if this test is negative, and there's no reason to suspect, to think that that you've been exposed to HIV within the last 4 weeks. There was no HIV exposure-prone event within the past 4 weeks, and there were no signs of symptoms that might be compatible with an acute HIV infection within that time frame. In other words, having fever, sore throat, rash, and enlarged lymph glands, for instance, then we can start. It's okay, it's legal, it's to start PrEP based on a negative point of care test while waiting for the results of the official laboratory test, which would come at a later stage. So having a negative HIV test, having no symptoms within that might be suggestive of an acute infection within the past 4 weeks, and having had no HIV-prone exposure within the past 4 weeks, that is when you're clear to start. If there's doubt, if in doubt, then the decision should be deferred. You should be wait to be more patient and wait for two more weeks or 4 more weeks, and then perform another HIV test, a laboratory test, to make sure that you're not positive before you embark on the on PrEP. Now, it's important to stress out that we prefer blood tests, because in some countries you can also perform an oral rapid test for HIV, buy them in the pharmacy, and these tests use saliva. Blood tests are more accurate and better detecting recent HIV infections, and therefore we prefer blood tests for this purpose. Now, if the conditions in the first bullet are not met, and I've added this sentence here just as for completeness, to make the picture complete. If a person has been on PEP or PrEP recently and wishes to restart antiretrovirals for preventive, for prophylaxis purposes, then we need to perform another exam, another blood test, which is an HIV RNA test, which tests molecularly the presence of the virus in one's blood. It is very accurate, however, it is by far more expensive, and is not a routine exam. Okay, now, assuming that we now are sure that that a person who wishes to take PrEP is HIV negative, we move on. And we're still within the framework of the baseline assessment before we start. And the second element here is to rule out any other sexually transmitted diseases. And we do that by performing screening tests for chlamydia, gonorrhea, and syphilis. Now, chlamydia and gonorrhea, these are tested for, or ruled out, by swabs. Swabs are taken rectally, orally, in order to detect proctitis or pharyngitis caused by gonorrhea or chlamydia. And we also perform a urine test for these two bacteria in order to make sure that there isn't any urethritis caused by these two. Syphilis is a blood test because we test for antibodies. We look for syphilis antibodies, and we do everything within the same blood test, but together with the HIV usually, so the patient doesn't have to be the person. They're not patient, they're not ill, perfectly healthy. They are being pricked only once, of course, for everything. We do not prick them repeatedly for each and every test. Now, there is a version of oral PrEP. All oral PrEP regimens contain a drug that is called tenofovir, together with another drug. These are always two drug combinations. But tenofovir can come in two versions. If this version here is used, tenofovir alafenamide, if this one is used, it is a bit more expensive, but it is associated with less kidney and bone damage on the long run. And I will be mentioning this very shortly as well. And then we also have to make sure that as a baseline, one's cholesterol and triglyceride levels, in other words, one's lipid profile is okay before we start. Because although this derivative, this version of tenofovir is associated with lower incidence of kidney and bone damage. There are no free meals. It is associated with some other harms, and that is the main issue here. It has been associated with elevated lipid levels. Now, all those who take tenofovir, whatever the version of oral PrEP, have to make sure before they start that the kidney function is within normal limits, is okay. And we do that by a blood test that is called creatinine. That is a marker for us that helps us assess one's kidney function. Now, it is possible that once a person starts PrEP, starts taking tenofovir, you will see, following the initiation of tenofovir, we will see changes in the blood creatinine levels. Usually, these are very mild changes. It might go up a bit, but in most instances, it still stays within the normal range. And it is not associated usually with any long-term health issues. And once a person decides to stop PrEP, usually kidney function goes immediately back to normal. Very rarely, tenofovir has been associated with serious kidney issues, such as acute kidney failure of a certain kind, and even more than that. And that is why we make sure that we test your baseline kidney function, and we make sure that while on PrEP, we monitor one's kidney function regularly in order to make sure that this doesn't happen. So a person who's taking PrEP and is being monitored accordingly, according to the guidelines, is well protected. So no worries here. Another issue that is screened for at the beginning is hepatitis B. And why do we do that? We do that because hepatitis B, firstly, shares the same modes of transmission. It is bloodborne, and it is transmitted sexually as well. And how do we screen for hepatitis B? It's a blood test, just like syphilis, we screen for antibodies. Now, if we happen to find somebody to detect hepatitis B, which is, by the way, worldwide, if we look at WHO data, then we're talking about the prevalence of hepatitis B is 5 times that of HIV. Then basically the patient is going to take PrEP, is very lucky because the medications that are used for PrEP, tenofovir and lamivudine, that is the second drug within the oral PrEP 2 drug combination, they are both active against hepatitis B. They are both used to treat hepatitis B, and that is terrific. That is very good. However, a problem might arise if a person who is hepatitis B positive or has an active hepatitis B infection takes PrEP and then stops, because then the hepatitis virus can rebound and cause liver damage. So having hepatitis B is not a reason to avoid PrEP. On the contrary, it's okay. It's very good to take PrEP and make sure that the replication of the HBV virus is under control, is decreased to undetectable levels. However, if PrEP is then stopped, liver function should be monitored very carefully to make sure that there aren't any HBV-related complications. Now, the guidelines here only mention hepatitis B, but it is an excellent idea to screen for hepatitis C as well. It is an excellent opportunity to do so. Firstly, hepatitis C is a bloodborne infection, and amongst men with sex with men, it can also be transmitted sexually. Now, today we have excellent treatments for hepatitis C that can eradicate hepatitis C within 1 or 2 months. So missing such an opportunity to make a diagnosis and treatment and treat it is not advisable. So screening for hepatitis B and hepatitis C as well are highly recommended here. Now, we as infectious diseases physicians who deal with prophylaxis, with preventive medicine, we all know that prevention is better than care. So usually we use these opportunities to discuss, to offer other preventive measures And in other words, we offer vaccines, and the vaccines that are recommended by the European guidelines when we discuss the initiation of PrEP are the following. If a person is negative for hepatitis B and hasn't been vaccinated against hepatitis B previously, then that is an excellent opportunity to vaccinate that person if they so wish. Hepatitis A is a foodborne illness, however, amongst men who have sex with men, it can also be transmitted sexually. So being vaccinated against hepatitis A, if someone has not been vaccinated before, would be highly advisable. That's a great opportunity to do that as well. Other vaccines that you might be familiar with are Gardasil. Gardasil 9 is available here. It's a vaccine that protects you against human papillomavirus. Human papillomavirus can cause warts, viral warts. However, some serotypes of the virus are associated with malignancies, and essentially in women, these would be cervical carcinomas, malignancies of the cervix, and in men, we're talking about anal carcinoma and penile carcinoma. So being vaccinated against Gardasil, human papillomavirus using Gardasil is highly advisable, highly recommended. And nowadays, of course, I'm sure you're familiar with the new kid on the block, which is monkeypox, and being vaccinated against the monkeypox virus. Mpox vaccine that's also an opportunity to get this sorted out, get this covered as well. So what is the effectiveness of PrEP? Well, if PrEP is taken daily and adherence is 100%, the data we have now is that the effectiveness is sky high. It's about 99%. So it's very, very high. However, you should know that PrEP works when the drugs that are used reach appropriate levels within the mucous membranes. In other words, within the rectal mucosa, the vaginal mucosa, and so on. So oral PrEP reaches maximum drug levels associated with protection when it comes to receptive anal intercourse after about a week's time. So it's not that you start PrEP and the following day it's there and it's working. You have to be patient. It takes a week. For vaginal sex, it takes a bit longer. It takes about 3 weeks, 21 days. Now, surely you've all been familiar with this regimen here. We call it on-demand PrEP, intermittent or event-driven PrEP. That is when someone is taking oral PrEP not on a daily basis, but on an on-demand basis. The regimen consists of 2 pills that are taken at once, up to 2 hours before the exposure, before having sex, and then again 1 pill 24 hours after the encounter, and the fourth and last pill 48 hours after the encounter. Now, that regimen has been only tested in the MSM population. So it's not recommended, it hasn't been tested in other populations who might need protection from HIV. It is not approved by the FDA, it is not recommended by the CDC, and it cannot be used in people who have HPV infection, because that would mean starting the medication and stopping it alternatively. So this would be causing, basically, it would be an episodic exposure to the drugs, which might be associated with flares of liver disease. So only for MSMs, those who are HPV negative, and we know from a very large study conducted in France called the Hypergay study that the effectiveness of an on-demand regimen is somewhat lower. It is about 88%, so it's not as high as that of the daily regimen. Now, we've reached the stage when the person has been receiving their prescription, they're on PrEP, everything's fine, and how do we move on forward? So the next point of assessment would be after 3 months have elapsed. So at least every 3 months, there should be a formal assessment. And what do we do after 3 months? We do the following. Firstly, we have to repeat the HIV test. and we use a laboratory test. So a point of care test is not enough here. We have to perform a formal HIV test. And we also make sure that there aren't any signs of symptoms that might reflect an acute HIV infection before we continue. And this is why in all countries, it is recommended that the prescriptions for PrEP would be limited for a 90 days period, because they should officially not be renewed until one knows for sure that after 3 months, HIV test remains negative. And then we renew the prescription officially. Now, this is, of course, also an opportunity to assess one's adherence, barriers, challenges that are associated with adherence, and provide support if such support is needed to help you stay on track with the medication. Now, if the person taking PrEP is a man who has sex with men, then every 3 months we have to screen for sexually transmitted diseases, the same ones that I've been mentioning before: chlamydia, gonorrhea, again with swabs, and syphilis, which is a blood test taken together with the HIV test, looking for syphilis antibodies. Now, these tests is being these screening tests are being performed every 3 months repeatedly, even if the person is entirely asymptomatic, because in many instances, pharyngeal, rectal infections, sometimes also, of course, urethral infections, are asymptomatic. And we do want to make sure that we do not miss these asymptomatic infections, because firstly, we know that people on PrEP have higher incidence, a higher prevalence of these infections, and we want to break the chain of transmission. We want to treat in order to make sure that the infection is not being transmitted to other people within the community. Of course, we also might be using this opportunity, this encounter every 3 months, to discuss ways of further reducing the risk of HIV and other sexually transmitted infections. As said before, behavioral issues, condom use, vaccinations if not been performed until now, etc. So this was every 3 months. We move on to the next point of assessment, point in time, which is every half year, every 6 months. And what do the guidelines say that we should be doing every 6 months? If the person on PrEP, taking PrEP, is above the age of 50, or if they had a reduced kidney function when started PrEP, you remember that before starting we also evaluated the kidney function back then we should make sure that we again send for creatinine, evaluate, assess kidney function after half a year before moving on, to make sure that your kidney health is fine, is okay, that we're not missing anything there. If the person taking PrEP has any other kidney diseases, has background illnesses that might predispose them to kidney damage, such as diabetes or blood pressure, for instance, then the blood test might not be enough. Sometimes we also need to check the urine for protein in order to look for other signs of kidney damage here. And as I mentioned before, we might see small increases in the lab result called serum creatinine. That is usually not a reason to stop PrEP as long as kidney function remains at a safe level. And of course, just as after 3 months, after 6 months, it is also a very good opportunity to reassess how you feel about PrEP during the follow-up visits, and let you know ask you whether you have any concerns, any expectations, whether you think about stopping, of continuing, and etc. And we move now to the last assessment point. What do we do every year? So every year we monitor one's kidney function, regardless of one's age or other predisposing conditions. So kidney function at least every year. And again, if one is taking that version of tenofovir alafenamide, which might influence one's lipid profile, that is again an opportunity for us to check the lipid profile again, cholesterol, triglyceride, check your weight again, because tenofovir alafenamide might be associated with slight increases in weight gain. So that's an opportunity to check these as well. And you remember that amongst MSM, men with sexual men, sexually transmitted infections should be screened for every 3 months. In heterosexual population and in women, the current recommendation is to do that at least every year. So a bit less frequent. What about stopping PrEP? If you wish to stop taking daily oral PrEP, you should know that protection would gradually be decreasing over the following 7 days. So we advise to wait at least 7 days after the last exposure before you stop, to make sure that you're well protected. Now, we know from studies conducted in many parts of the world that there are increases in the chances. We see an increased incidence of new HIV infections just after PrEP is stopped. So it's important to make sure that you know that such a thing might happen, and that you take the necessary measures to try and decrease the chances of getting HIV after you stop, the immediate period just after you stop, using other methods. And that is the last slide, so we're about to end. Other considerations. PrEP may be continued during pregnancy and breastfeeding if the risk of acquiring HIV persists. So pregnancy and breastfeeding are not contraindications to PrEP. If you remember at the beginning, at the start of my talk, I was saying that tenofovir might be associated with both kidney and bone health. I was constantly mentioning kidney issues. So what about bone health? Tenofovir might be associated with reduced bone density. However, these changes in young and healthy individuals are very minor. They're really very small in proportions, and that is usually not a consideration at all when we're talking about individuals younger than 50. When someone is either older than 50 years or has another predisposing factors for anything that has to do with decreased bone density, for osteoporosis at an early age, then we screen at baseline for bone density as well by performing what we call a DEXA scan, which is a bone density scan. Another thing that you might have heard or have questions about is doxycycline. That is an antibiotic that is taken post-exposure. We call it doxy-PEP. And here we talk about 2 tablets of doxycycline. Every tablet is 100 milligrams, so it goes of 200 milligrams taken within 3 days max after an unprotected sexual intercourse. And we know that this might prevent quite well getting a bacterial sexually transmitted infection, mostly chlamydial infection, syphilis, and we talk about a considerable extent, about two-thirds less. So we diminish by taking doxy-PEP, we can diminish the chances of acquiring chlamydia or syphilis by about 2/3, and to a lesser extent, about 1/3, the chances of acquiring gonorrhea. However, the caveat here is that we still do not know, we're still are not familiar with what might happen with taking doxycycline long term, many times, many episodes during one's lifetime, during a year, during a month or so, how much it affects our microbiota, our own population of bacteria within our systems, within our gut mostly, and whether this might affect resistance patterns of sexually transmitted infections that one might still acquire. But doxy-PEP is now a valid intervention that can be proposed to persons with repeated sexually transmitted infections on a case-to-case basis. So this is also another tool that can help substantially decrease sexually transmitted infections and can be provided alongside the follow-up that is offered to individuals who seek pre-exposure prophylaxis for HIV. Okay, so questions. I think there's one here in the chat. No, there isn't.
Great. Thank you, Danny. So let me just stop the recording first.